Association of Thoracic and Vascular Surgeons and the editorial member of the Journal of IACTS, Journal of Cardiac Anesthesia and CTS in ET. Dr. Jawali is currently the Chief Cardiovascular and Thoracic Surgeon at Fortis Hospital, Bangalore. Dr. Jawali, in addition, has been recipient of many awards which included Karnataka Rajyotsava Award, PC Roy Award for Medical Excellence, Kempegoda Award for Outstanding Citizen by the Bangalore City Corporation, the Citizen Extraordinaire Award by the Giant International, and the Harvard University Lifetime Achievement Award for Medical Excellence in 2006. On the occasion of His Holiness Jagadguru Shivarathri Rajendra Mahaswamiji annual oration, we are proud to present this citation to Dr. Jawali. Dr. Jawali, please join us here in front.
To listen to this extraordinary humanistic clinician and a leader in cardiac surgery. We kindly request our awardee, Dr. Vivek Jawali, to deliver this sign.
I am indeed honored to be here. Good afternoon. The dignitaries on the dais, in the auditorium, teachers, students, my old friends here, ladies and gentlemen. I've chosen this topic because this is a kind of an original work from Bangalore, a Karnataka work, and I thought that will be the fitness of the prestige of an oration like this. Awake, non-intuitive, that means without introductory cue, without anesthesia, general anesthesia, conscious, cardiac surgeries on either heart-lung machine, which is called as cardiopulmonary bypass, or beating heart, that is without cardiopulmonary bypass. Giving our pranams at the lotus feet of His Holiness Jagadguru Sri Shivarathri Rajendra Mahaswamiji, we shall begin this oration. You all are from JSS, so you know, and I don't have to dilate on the 1,000 years of legacy of this mud in whose premises you all are working or studying. So without dilating much on that, I will come to the subject proper. You all know in general surgery, obstetric gynecology surgeries, you use extensively the epidural analgesia. It has been used for cardiac surgery for more than 20 years as an adjunct to GA by some of the people who were enrolled by its usage, like us. And it has started now spreading. The worldwide published use is now large enough to determine that there is no additional risk for epidural use in cardiac versus non-cardiac surgeries. This is an anecdotal case I will begin this talk with so that you understand what am I talking about and what is the magnitude of this talk. Before I go to the case, I want to make a point because I see 2/3 of the audience is students. You must understand that when you look at the history of medicine, there have been progresses and progresses every year. We have come long way. If you look at the history of how we came to know where heart is, 20,000 years ago, in a cave in Pindal, there was an elephant drawn by some ancient man and the heart is drawn where it should be. And from that time,
we have come wrong way, and it is because of a continual fracture in our thinking by disruptive thoughts. Most of the times, these disruptive thoughts have been brought in by innocent people like you whose mind are openest. A good example for that is there was an essay competition in Bangalore on science essays. And there was this girl from Sophia's who won the prize, 8th standard, and she wrote an essay with the concept that a long elevated motorway that we have built from the airport to the city, it has got 2 flanges on the sides, and why not we have big hooks and hanging roadways all the way from that end to this end for cyclists. And this is such a doable idea. So this needs open mind. And a lot of times the disruptive and sustained technologies have come from minds like yours, which are open. So you must not lose this, the openness of mind. If you look at coronary bypass surgery, we started doing it in 60s, and we were sophisticating on heart-lung machines, stopping the heart, churning the blood on machines, which is not something that God has allowed us to do. But only recently, somebody from a small town called Curitiba in Brazil came up and said, you are operating on the heart, not inside. Why do you need to stop the heart? So do a beating heart surgery. And they started with a cumbersome way. Today, almost 99% of the heart surgery that I do are beating heart surgeries, and 60% of India's bypass surgeries are beating heart surgeries. The topic that I'm talking about is something like that, out of the box. And but so doable, so cheap, doesn't cost a lot of fortune or rocket science. So this was a patient we had a year ago, 73 years old, significant obstructive pulmonary airway disease. The FEV1 was very low. He had a drug-controlled myasthenia gravis. He had a severe calcific aortic stenosis with a thickened ventricle. He had a triple vessel disease of the coronaries. All the coronaries were choked. He had an old anterior wall MI, and hence his ejection fraction had dropped to 28%, so the heart was very poor. Now this guy can't be tackled. He has to die. He needed a multi-vessel bypass surgery and aortic valve replacement. This guy has a very poor lung. We have to do something for his myasthenia, otherwise he would be stuck on ventilator for years, for months at least. But with that COPD, a tracheostomy was a must, and months of ventilator assistance was a must. So not a good thing to do, and maybe let him live as long as he lives. The only way out was this work that we have been doing for the last 1.5 decades, the awake cardiac surgery, where you don't intubate, don't paralyze, don't play with the respiratory tree, and so don't play with his myasthenic status by paralyzing him. But the LV was so bad that just to sustain the LV, we needed ventilator as a treatment. But that's a traditional thinking. Is it required? And we are so experienced, so we said we will try, we will do this awake, and if it does well, maybe it will do something to our mindset also. So we went ahead and operated this man awake, non-intubated, without general anesthesia, without muscle paralysis. We did an aortic valve replacement with a tissue valve, and on-pump bypass surgery, because I had to cut open the heart and do the aortic valve replacement, so it has to be on heart-lung machine. With 4 grafts, we did a thymectomy to treat the myasthenia. And this done not last month because that slide is old. It was done without cooling him because he was awake. He can't be cooled, he'll start shivering. And with blood cardioplegia, that's a technology to keep the heart properly preserved during when it's stopped. There was, this patient had a unimaginable recovery. My cardiologist, my anesthetist also was jittery that you were going too far. But we did not require any intra-aortic balloon pump for that bad LV. He had a dramatic fast tracking, and on the 5th day I discharged him like a simple case. Now it had some points which this case made a statement to us, that it told us that we were living in the box for too long, and maybe in our ICU, which is a very state-of-art ICU, we have been overdoing quite a lot of things, creating a huge amount of iatrogenic damages to these patients. And it really woke us up to the possibilities that this can be taken to many miles ahead. With your opening of the minds with this case, I'll go ahead. Now, this was an old case, maybe 10 years back I've done. Okay. This is a 55 years old teacher, school teacher from Goa, Melina. She had come to me for aortic valve replacement. Those were my early days. And we did I have stopped her heart, she has a flat line, ECG, blood pressure, everything. She's on heart lung machine. And she was wide awake. My anesthetist could wake her up very easily, talk to her. And she, at the end of surgery, there was no IPPR, no venous congestion, had a very dry field. She recovered quite dramatically because when you don't intubate somebody, the tracheoesophageal reflexes are not hassled and they can start eating, drinking immediately. We can make them sit up in the bed and dangle their legs, and they can also go on a fast-track physiotherapy, and their recovery will be quite dramatically different. So you can see the heart is stopped, there is a flat line, this lady is not intubated awake. I am putting a new tissue valve in her aortic position. And at the end you can see when she's being wheeled out, at the end if you see the monitor, the blood pressure, the heart rate, the ECG, the rhythm, everything looks, the field is very dry. And that happens when there is no IPPR, positive pressure respiratory assistance, which will cause venous congestion. These kind of cases encouraged us quite a lot in that era. So come to the basic question that for years and years we have been doing these major operations on general anesthesia and we are very well settled on that. Why do you want to remove that comfort zone? Who asked you what is the necessity? The necessity is there. You must understand, you all are students of physiology and you know how complex is the ecology of the ciliary mucosa or the entire respiratory tract. Right from the time the air enters your nose, gets filtered, crude filtering by the hairs, the humidification and warming by the sinuses, then the very minute ecology of the ciliary mucosa. And what you do, you paralyze, you stop, make that person indefensive, and then pass a crude plastic tube or a rubber tube, which in country like ours is used 100 times again by re-sterilizing. You don't know the validity of the sterilization. Then you have all kind of junior Johnnies taking care of this patient, don't even know how to suck the respiratory tract. They may attach the suction and just put the tube inside and move up and down. And if somebody does an endoscopy maybe after that, we'll see so many traumatized lines inside the bronchial tree. And they will colonize with the bacteria, they will fester. You don't know what kind of surfactant losses will happen, what kind of best lactasis will happen. And we have no idea about the quality of machine maintenance, quality of people around. Most of the time they are very inferior. The seniors would pick the bag at 4 o'clock and go off. So that is not so simple to take it for granted. And in majority of the major centers where there is a mass production, the patient would just go on ventilator overnight and paralyze helplessly. So this itself will require a mammoth amount of monitoring, which is expensive, and a lot of iatrogenic hassles can happen of missing hypovolemia, over-treating, under-treating heart rhythms, all kind of things happen because this patient is completely knocked off and also helplessly paralyzed and on this ventilator. So to avoid discomfort of endotracheal tube, to avoid respiratory trauma, to avoid mandatory sedation and muscle paralysis, which is mandatory, to avoid mechanical ventilation, which may not be the best. So lack of stress response. When you intubate somebody, there's a stress response. You don't do that, there is no stress response. No injury to the oropharyngeal structures or their reflexes, can eat and drink immediately. No infection of respiratory tract. Patient as a cerebral function monitor. If you are doing an off-pump bypass surgery to somebody, you all know, you must be seeing in Mysore, so many places, we are doing beating heart bypass surgery. When doing beating heart bypass surgery, you lift the heart, you are doing grafts on circumflex artery, and you may inadvertently press the heart, insert the heart quite a lot. Your pressures may come down. There may be insensitive surgeons, insensitive anesthetists, and you may accept low pressures for a long time. And that will do something called neurocognitive disorders. It will cause some fine demyelination. And these neurocognitive disorders can be very disturbing. There was a major paper coming from Duke University of 1800 patients, what happened to them in the sense of neurocognitive disorders. They studied these 1800 patients over a period of 5 years by neuropsychiatric follow-ups by the neurology department and the psychiatry department, and they found fearfully that 50% of this lot of 1800 bypass surgeries showed some fine intellectual changes, memory, emotion management, and all those things. 50% of this 50% showed very fearfully that the disorder became progressive. If he's an ordinary Joe going to office at 9 o'clock, coming back 5 o'clock, not taking major decisions, may have some forgetfulness, some emotional discord, it's okay. But if this is a CEO, a prime minister, a major minister, somebody who has to do snap decision, a surgeon, then there is unmasking of what damage has happened. Many times I wonder, Manmohan Singh in his first term before his surgery and Manmohan Singh in the second term after his surgery, there's a difference. I don't know. So, when you have a patient awake and somebody inserts his pressure badly, there will be hypoxic irritability and he would just not allow you to do that. Cerebral function monitor at a 0 paisa and absolute. Somebody is doing a calcific aortic valve replacement and allows some debris to fall unknowingly and the debris flows and gives a stroke. And there's a thromboembolic episode. Patient is awake, you will know at the hour 0, second 0. You can start all your actions immediately. So these are not to be taken lightly. These are very important tickets. Ideal cerebral perfusion pressure. When I put somebody on heart lung machine to do a valve, then what happens is there is a flat pulseless flow. But if I am doing a beating heart bypass surgery, the pulsatile flow is still maintained, which is meant by God to do something. Nothing that we have in our systems is purposeless. It is evolution of so many million years. So a pulsatile pressure, and by doing awake you maintain a good healthy pulsatile pressure to all the organs. Then avoidance of potential brain damage during off pump by not allowing the pressures to drop badly. Advantages of using continuous high thoracic epidural anesthesia due to the use of high thoracic epidural. There is a hemodynamic stability because there is no stress response. That software of stress response is very well preserved. And if I see we operate in almost 7 theaters. On pump, under GA patient, on GA, but beating heart surgery patient and awake. And I see in that theater, there is such a rock steadiness about the heart rate, the pulmonary artery pressure, the systemic pressures. So this definitely has a living proof all the time for us. There is a superlative analgesia about which I don't have to say. And now what we do is the catheter that we put overnight for the epidural, we don't remove the catheter. We maintain the catheter till the patient is discharged and there is a Baxter-made pump in the patient's pocket which keeps on giving the bupivacaine. And they get a very good analgesia without ingesting too many inserting tablets which could add the stress cascade that is already there in minor shades because of the stress. Then there is a reduced oxygen demand overall by all the organs and there is an optimal distribution of the coronary flow which is very important when you are doing the coronary artery surgery. The advantages of using continuous high thoracic epidural anesthesia, apart from this attenuation of stress response, there is an improved pulmonary function and reduced incidence of AF. All the elderly who are septuagenarians, they have a high incidence of getting thrown into AF. And if they go into atrial fibrillation, it may be paroxysmal for some time and it may become in a large number of patients chronic. Atrial fibrillation will require lifelong anticoagulation, and that's a very, very, very bad news. And if you don't, they will get a stroke. Stroke in this country, unfortunately, is worse than death. So that's a very big ticket. And that, there is a dramatic reduction of that incidence. And also, because you don't intubate, you do not incite any bronchoria. And because you do a high thoracic epidural blockade, that is a good therapy to cause maximal possible bronchodilation. No bronchoria, maximal bronchodilation is a godsend for a patient who has got a bad COPD or bronchial asthma. And because of that, and our publications and people now, it's become quite popular. I am getting a series of doctors from the white world in the Europe and in the United States who have a bad pulmonary functions and who need a bypass surgery, and they get referred. and we have done scores of them. So for these kind of patients, thymic, myasthenia gravis, this is quite a tailor-made situation. So decreased incidence of neurocognitive dysfunction, I explained you about that. This paper by Colin Royce in Royal Melbourne, in the current opinion in anesthesiology in 2009, the summary was several large case series have been added, this is a meta-analysis, have been added to the literature without cases of spinal damage. The estimated risk of epidural hematoma is 1 in 1,20,000. Now what is this? The worry is you are going to hyperonize these patients for heart surgery. And if you have caused some minor hemorrhages by the needle, you may cause a hematoma. You cause a hematoma, then you may cause a paraplegia, quadriplegia, all kind of damage. That is the biggest worry. But there are enough evidences that that risk is very negligible, and our vast experience also has shown the same. What we do in my hospital is that this is a private hospital. We have to be very sensitive about the billing. This is Jayaprakash, one of my anesthetists at the junior cadre. Everybody in my team is very lubricated on the procedure of doing this kind of high thoracic epidural catheterization. And this we have been doing it for more than 20 years. So everybody is quite an expert. So what we do is we admit them the afternoon before, immediately as soon as they are